Welcome to episode 5 of 101 Mobility Conversations. Scott, welcome to the Mobility Connection and spending some time with us this evening. Appreciate you joining the show.
Thanks for having me, Joe. Appreciate being here.
Hey, if you could just start off with just the basics, help us understand who you are and what you do and why in the world you and I are talking together today.
I'm an orthopedic surgeon. I practice primarily sports medicine, the knee and shoulder in particular. But I've been in practice for about 27 years. I'm in private practice just outside of Boston, and I have a lot of passions outside of taking care of patients as well. So I'm the chief medical officer and founder of OrthoLazer, which is a unique franchise that we have around the country, which helps to keep people moving. We'll be happy to discuss that. A big fan of opioid-sparing surgery. I've lived through the opioid epidemic and really was one of the earliest providers trying to come up with alternative solutions for our patients. And as well, big fan of nutrition, perioperative health for our patients, and just trying to keep our patients moving as best as they can.
Well, I'd love to start with the opioids because I'm married to a pharmacist, and so obviously pretty close to this. And she's talking about this area all the time in the house. So, love to know your philosophy and your opinions on this and how you're practicing it.
Yeah, so first and foremost, I think opioids still have their place within our society for patients that are near death, for cancer, severe trauma. But what happened really was in the sort of very beginning of my career in the late '90s or mid '90s, there was a big push from pharma. So I'm sorry, specifically Purdue Pharma, where they sort of developed this marketing campaign that opioids were unaddictive. They could be taken easily. Less than 1% of patients that supposedly went on these sort of super new opioids would become addicted. I literally just watched a commercial from 1998 from Purdue Pharma, and it's just shocking, the false information that was provided both to physicians as well as patients. And we were doctors, we were doing what we were told. We weren't, there's always some bad apples and things, but at the end of the day, our entire medical society was completely duped by this concept and idea that opioids could be used as a way that would be minimally addictive. And it was just tragic. The number of lives that were lost, the communities that were devastated by this, the professional careers that were ruined for doctors that were following the advice and counsel of this pharma company. Pain became a vital sign. All these things were happening that were pushing us to use opioids for pain because we were told they were minimally addictive and not very expensive. And the truth is it couldn't have been further.
You think we would have learned our lessons when they were telling us that cigarettes were good? I remember those commercials when I was a kid.
It's really amazing. And, to this day, the way that the FDA monitors the process of commercials at this point, and you see all the little things on the bottom of the screen, right? Because they've been burned so many times at this point now, it's very particular. But yet, direct-to-consumer advertising is still one of the biggest plays for big pharma, to be able to move their product. So you always have to take all these things, with a grain of salt as you're watching and identifying what the next great drug is going to be.
Maybe a silly question because I did mention I'm married to a pharmacist, but I've always found the direct-to-consumer advertising odd. If it's the doctors making the decision in the best interest of the patient, why are they spending so much money trying to get me to take a particular medicine when I'm not a doctor and would never even want to give insights on what medicines I should be on?
Well, people do get influenced by the tube in front of them, especially, with all the screens that are present there at this point. I could tell you, even for me, to be perfectly honest, Joe, I graduated medical school 30 years ago, right? There's classes of medications that are out there and being utilized that I know nothing about. I have to Google them just like you do to be able to figure out, when there's new classes that come out like the GLP-1s, which are the weight loss medications that are good for type 2 diabetes, they affect us as surgeons because you have to know that your patients are on these medications. They can slow your gut, which therefore changes the paradigm for the risk of anesthesia. So there are certain, classifications that we study as they come through, but it's not easy. There's a lot of new medications and new things that are always coming through the pipeline.
So is the tide changing? Is there a growing medical community that's looking at these medicines differently and how they're applied and used and the impact?
Well, I think it's really based on your specialty, right? Is really what it comes down to. And then as a surgeon, you need to really be aware of the medications that your patients are on, how they're going to affect the healing properties. So, for example, there are these new classification medications for patients that have rheumatoid arthritis or inflammatory conditions that really immunosuppress your body. You can be at risk, increased risk for infection. So, to our listeners that are out there in particular, it's super you have an updated list of your medications for any time you're considering a surgical intervention so that all of the doctors that are in play that are going to be helping you can provide you the best possible.
It's interesting you talk, we talk about opioids and we're talking about nutrition and also keeping them moving, just making that transition over nutrition. What has been, and a quick story, my mom had major back surgery about 10 years ago, and it was serious. They had to, cut her open and fix a disc and do some major work. And I remember specifically two things the doctor told her, and she had a fantastic doctor up in Maryland. One was, "You're gonna be up and moving the next day." Like, they had her out of bed. She was whining and complaining, and my brother Johnny and I were there, and it was just horrific to watch my mom just be so stubborn. But the next thing was, the nutritional regimen that he had put her on was like, I remember, this is what she's gonna eat, this is what she's gonna consume, and it was really tied to just keeping her healthy, and, yeah, I was impressed, and different from, the surgeries when I was a kid where you were in hospital for a couple of weeks and you stood, laid still. It was amazing to watch that transformation, to get her going and make sure what you put in that body's right.
Yeah, and it should be not just, at the time of the surgery or after the surgery, but actually before surgery. And that's one of the things that really was not taught to us in medical school, but probably the greatest unmet need in surgery right now is nutrition. And so if you think about it, you're exactly right. I mean, when I grew up early in medicine, you got a hip replacement, you laid in the hospital for 5 days, then you went to the rehab facility for 2 weeks because we narcotized you. You were on opioids, you couldn't move, you couldn't poop, you were nauseated, and you couldn't get out of bed. So for literally 3 weeks, we then wean you off the medications before we get you home. But now the vast majority of these surgeries are being done in the ambulatory surgery centers. Even for our Medicare population or disability, they may be getting done more or so at the main hospital still, but more and more surgeries are being pushed to outpatient. And so the unmet need in nutrition in particular is the something called the essential amino acids, which are the amino acids are the building blocks of your protein. So you can if you're undergoing a surgery, you need to have all of those things available to repair yourself, right? And so you need protein to be able to repair your body. And so the essential amino acids are not amino acids that your body can make on their own. You have to ingest them. And so the studies have shown that if you start ingesting these essential amino acids 3 or 4 weeks in advance of your surgery, you're providing that nutritional support that can allow your body to heal even better as they go through. So I would highly recommend to our listeners, as well as the people that are viewing, if you're undergoing surgery or going to be scheduled for surgery, talk to your doctor about, what can I do for my nutrition in advance of surgery to give us the best possible chance of having a positive outcome.
Does that also apply, doctor, to not just surgical recuperation, but also just therapeutic? They pulled a muscle, ligament tear, and things like that, where, in the space that we work, where we deal with a lot of seniors, that's common. I need a wheelchair, I need a lift because, I pulled a muscle. And does that also apply to that?
Yeah, 1,000%. I mean, this is a great time to talk about it, right? We have the Paris Olympics, starting next week, and all of these, athletes and these high-end athletes, trust me, the nutritional support that they get is just as important as their workout schedules as well. And so we're all the same. I mean, we may not be competing for a gold medal, but at the end of the day, you want to get up the stairs if you can. You want to walk around your house. You want to be healthy. If you do have injuries, then I do think that this type of nutritional support, I mean, we think of, probably the thing that was ahead of its time is Ensure, right? We're all familiar with Ensure, which is this protein shake that they give you at the hospital. Like, you look back on it now, I'm like, that was pretty good. That was a smart idea. So, yeah, I mean, I would say to again, your listeners, if you've had injury, consult your primary care doctor and say, there's some nutritional things that I can do to help speed my recovery to keep me moving.
Why don't you think that's more public information about nutrition and the impact of aging and recuperating and healing? Because it doesn't seem to be something that's really public information out there.
It's common, I can assure you. I have my own podcast called The Ortho Show where we bring on unique individuals from the orthopedic industry. And there's companies such as Men Therapeutics, Accelerated Recovery that are literally building a business specific to this where it's available, for patients. So even for example, for our listeners that have Medicare, for example, you can get started on these nutritional supplements and it becomes part of your Medicare program. I mean, they'll pay for it to have the information as well as the material sent to you. So I would say that you're absolutely right. It should be more public knowledge. It should be something that we're all striving to do. But I think that there is a real push at this point to bring it to the forefront.
It's interesting. You mentioned on your opening monologue that, getting seniors and people with disability up and moving and staying active. And you and I talked prior to this, and I had a little bit of background. So you want to talk about how you're doing that and your efforts to spread that word?
Yeah, so it was really born out of my passion to seek an alternative option from opioids in the opioid crisis. And so I was routinely, asked to review new products, new ideas, new concepts. And one day a friend of mine said, "Well, have you thought about laser? Photobiomodulation therapy. Photo meaning light, bio meaning life, modulation means to affect." And I said, "Well, it certainly wasn't anything I was taught in medical school, but, I had a friend who had trained with Jim Andrews, who was the probably one of the leading sports guys in the world, taking care of all these athletes, and they've been using laser in their clinic for years." I said, "Well, let's give it a try." And I was really amazed at how well you could literally shine a laser light onto your body and you can create a healing effect. If you have the right wavelength of light at the right intensity, it can penetrate below the skin and get into your tissues. And it can go about 6 to 7 centimeters and get into your muscles. It can get into your joints and get into your bones. And you can change the metabolic cellular metabolism of your cells. So I ask you, Joe, do you remember photosynthesis? You believe in photosynthesis, right?
Yeah.
It was taught to us in high school, right? The sun comes down, it shines onto the plants and the trees. The trees then take the carbon dioxide, they change it into oxygen so we can all breathe, and then provide sustenance to the species on the planet. And it's this constant evolving process, but we have a sun. So I always say to my patients as we're talking about photobiomodulation therapy or laser therapy, we're a successful species on a planet for over 300,000 years. It should not come as a surprise that in our deepest genetic code, we are sensitive to light. And so we think of light, Roy G. Biv, right? That's the visible light spectrum. Then you've got infrared is to the right, then you've got ultraviolet to the left, and then you got crazy things like X-rays and gamma rays and all these things. That's all part of the light spectrum. But if you find the right sort of zone and the right wavelength, believe it or not, you can make your cells happy and they can actually have less pain and inflammation and they can keep you moving.
I have never heard of that. This is fascinating. So how do you practice that or apply it?
Yeah, I didn't learn any of this stuff in medical school, so I went to laser school, which I literally flew to Florence, Italy, and met with several professors in cellular biology. If I was going to stake my reputation on this new modality that I hadn't been taught, I'm going to make sure that it's something that works, number one. And so it's amazing. There's like literally thousands of clinical research papers on the basic science for laser as well as clinical applications. So we have at Mass General Hospital right now, Paolo Casano, who's an MD, PhD, as a psychiatrist who's using laser treatment transcranial for anxiety, for depression, for post-concussive. The brain is a big nerve, and that's a lot of nerve cells. And so what we do with laser is the light shines in. I gotta do this again. I apologize, but the mitochondria, which is
Yeah.
the powerhouse of the cell, right? And then, God forbid, we remember the Krebs cycle, which is like where your energy comes from. If you shine the light on that mitochondria, it gets excited. It makes more ATP, which is the building block or the energy of our cells. It brings in blood flow. It brings in healing cells called fibroblasts. And you literally can create an anti-inflammatory effect, whether it's in the brain, as we talked about, whether it could be your thumb, maybe it's your hip or knee where you have arthritis, or it's your neck or your back that has arthritis. And we literally can make you feel better. You go in for these treatments, they take about 15 minutes. You can't hear, feel it, or see it. It's a pulsed laser, so it doesn't create any temperatures. It doesn't create blisters. You can laser over your hip replacement, your spinal implants if you've got them. The metal doesn't heat up. And we literally go for usually about 12 treatments. And it's really remarkable how well patients can do. No injections, no medications, not a surgical intervention, and no significant reported complications. How good is that?
That sounds almost too good to be true, but
Yes, I know, I know. Well, that's why well, we have 20 centers open across the country now, and we just brought in our new CEO, Ron Meyer, who is a giant in the orthopedic industry. And so we just finished our Series A capital raise. We put money in the bank, and we're going to scale this so that we can we're going to democratize laser to the American people so that we can keep you moving so you can champion your personal success. Mobility is key to life, right? And you guys know that as best as anyone. Your brand and your company and your technology is built around keeping people moving. So that's what we do as a species. We have to keep moving to survive.
so this is fascinating. And by the way, I love going back to school. If I'm getting flashbacks to college. I tried biology, it didn't stick.
Yes.
Before I get to a couple of business questions on how you're going to scale the business, you've mentioned several times that you were not taught this in medical school 30 years ago. Is this now being introduced and taught in medical school today?
So photobiomodulation therapy is slowly working its way into the North American medical school curriculums, but it's very slow. But worldwide, it's very well recognized. And so when it comes to physicians in particular, it shouldn't come as a surprise that there's always a lot of skepticism. Years and decades of our lives to become experts, right? And the more you do, the less you know. You know a lot of things about a small area, right? I couldn't do brain surgery today. I wouldn't know what hormones to give somebody that has a thyroid problem or what cancer treatments are available. So I focus on the things that I do well, and that's what most doctors do. So with the concept and the idea of then asking a doctor to learn a completely new technique that they've never been learned. Most are skeptics. The Rogers curve of innovation, if you're familiar with that, it's this curve where you have the little chasm, right? Where you have to get to mainstream. Well, doctors are not a big fan of jumping across that chasm. So it's all everything. But that's true, not just with photobiomodulation therapy. If there's a new surgical technique that comes out, for example, where we use robots or whatnot, you have to take time out of your clinical practice to go learn something new. So doctors are not too keen on that. But eventually, I'm presenting in London, for example. I'm giving a talk for the Worldwide Congress on laser therapy or photobiomodulation therapy. And I'm going to show a picture of Joseph Lister. Everybody knows Listerine, right? The mouthwash. But Joseph Lister was famous because he was the first doctor to recognize that there were bacteria. So back in the day, if you go look at some of these textbooks and things, they would have something called the Ether Dome, which was at Mass General Hospital, where there'd literally be like 100 doctors in suits and ties sitting around watching a surgery. They didn't have anything, no gloves on their hand. They didn't wash anything, it was none of that. It was completely aseptic, and they couldn't understand why a lot of people were getting infections for this, right? So Lister was the first guy to recognize that bacteria were there. He said, you got to wash your hands, you got to put on gloves, you got to sterilize the instruments. And it was one of the most dramatic things that we've seen in surgical innovation by doing that. But it was met with tremendous skepticism. Nobody wanted to wear gloves, in the operating room. Think about what we do now. So I've always been in my clinical career willing to challenge the status quo and look for new concepts and ideas and find other people that sort of join in that process. We're going to work on it.
I read a book of that story about his story about the Listerine and how I think it was traced to birth rates too at one point too. I think he studied that, and I was fascinated about that whole story and all the detail behind it.
There was a lot of infections that were happening in the maternity wards, and they couldn't understand why all these women were dying. It's because they weren't sterilizing any of the instruments, and they were transferring bacteria from one woman to another in the bleeding aspect of when they're giving birth. So again, that was exactly that sort of timeline when they recognized that bacteria was the issue. Wash your hands and you can save lives. We still do that every single day. When I leave a patient room now, or before I go in the operating room, I wash my hands. It's amazing.
It was fascinating because that story was actually told in the context of statistical analysis, that because he tried so many different ways to prove, whether it's income or number of people working and everything else. And it actually got as simple as we're dirty, we're infecting people. And he was ostracized for that view too. I thought that,
Oh my God. It's exactly right. And so, but that's like when I first started talking about, I get rotten tomatoes thrown at me on the podium, right? Or even the idea, Joe, to not to minimize opioid use. I mean, what a foreign concept 10 years ago. So 10 years ago, if I get up on the podium, we started using a new medication, which is a long-acting anesthetic. So we all know anesthetics work. You can go to the dentist, you get a tooth out. But the problem is they usually, wear off in 6 to 10 hours, and it hurts like hell for a few days. But they developed this new medication, liposomal bupivacaine, that would last for 3 days. So we were operating on patients, and they were like not taking opioids. But yet the doctors and the societies and the hospitals wouldn't use it because it was more expensive and because it was going against the grain of what they had been taught. So, in that 10-year window, I've got some fantastic news again, for the listeners and watchers, is that the No Pain Act was just signed into law by President Biden in January of this past year, which now allows for CMS Medicare to pay for opioid alternatives in the hospital setting as well as for outpatient surgery centers, so that now we're encouraged as physicians to use these opioid alternatives instead of the opioid. So really, it's been, and that took every bit of a decade for us to be able to change the philosophy as to how people were thinking about these medications.
that's a really big deal because we start pushing that. It's how it gets paid really becomes a priority as to what they use. And so that's amazing. So back to the business. So you've got a leader, you've got funding, you've got a great concept. How are you going to scale it? And how do you see this business growing over the next couple of years?
Yeah, we're gonna grow slow so then we can rapidly expand. And I think that's the nature of Rod Meyer, who is our new CEO that just really signed with us about 2 weeks ago. We cannot be more excited having Rod. And I think what you said, Joe, is that, life is about relationships, right? You need to be able to develop a solid team to be able to do this. I'm an orthopedic surgeon. I recognize the importance of photobiomodulation therapy and how it's going to clinically help my patients. But, I have an MBA. I've never successfully scaled a franchise business to an exit. So you need to put these types of people on your team, and then you need money in the bank, right? Because you got to be able to do this. And so what we're going to do is we're going to identify the states in the country that really are very favorable to regulation on laser. And we're partnering with like-minded orthopedic surgeons, pain management specialists. They're going to actually be owners of these centers, which is important. You know, as physicians, I'm not sure if people are aware, but we're asked every day to do more. And we just found out from the same CMS that had about the No Pain Act that we're getting a 3% pay cut again this year. And that happens every year. The teachers unions, the auto workers, the screenwriters guild, the actors in this past year all got raises, right? And everybody gets a cost of living adjustment. Even with Medicare or Social Security, you get a cost of living adjustment. But for surgeons, for some reason, Washington seems to think that we're getting paid too much and they want to ratchet us down. So we continue they reduce our reimbursement every year to the point where many doctors are actually contemplating no longer taking Medicare because they physically can't afford to take care of the patients because the amount of money that Medicare is compensating them for routine visits or for surgical interventions isn't enough to cover their costs and their expenses. It's really very concerning.
Recently read something about this declining reimbursement rate, and it's crossing over that they're not replacing the number of surgeons in some of the key areas as well. So you've got decline in reimbursement and also a decline in supply of people available to actually do the work. That's not a good business model.
No, and it's funny. I'd like to say this out loud. I mean, the concept and the idea is somehow that doctors are making too much money and we're the source of healthcare rising costs. If you have a knee replacement done at a hospital, for example, Medicare, depending on where you live, pays maybe between $20,000 and $25,000 for the episode of care, and that's all. That's for the implant. That's for your time in the surgery. You got to pay the nurses, the staffing. You got to buy everything. All included. So how much do you think a doctor gets paid? So they don't get paid. So the doctor doesn't get any of that money. All that money, that 20 to 25,000 goes to the hospital, and the hospital then cycles it down and uses it as it needs to. The average doctor gets paid anywhere from $800 to $1,200 for that total knee replacement. And then we're covering you for 90 days. So that includes the next 90 days after the day of surgery. We're providing care for you, and we're not being compensated anymore for that. And so if you now take that $1,200, and take another 3% off this year and then another 3% off, we're all still doing it. Most of it are still doing it. But I want to make it clear, the cost of a knee replacement, it's not the surgeon that's driving up the cost. Okay. We've been involved with all types of programs with Medicare in high quality, cost effective management to try and reduce costs to the system. And we've shown that we can do that. So it really is, to be perfectly honest, quite unfair. So then you go to the business model of OrthoLazer, which is the name of our business, where physicians and surgeons can have ownership in a clinic. We value that because we're providing a service to our communities that have been devastated by opioids. We're providing a service that they need to keep people moving at a fair price. Our treatments are under $1,000. So, if you have, severe hip arthritis and you're looking to avoid surgical intervention, we give about an 85% chance that undergoing 12 laser treatments will provide you significant pain relief for a prolonged period of time. And so there's fair compensation to the doctor who is taking time to identify treatment options that are available for patients. I will say our model is a patient pay model. It's not covered by insurance at this time. We could have a whole show on that. But at the end of the day, the scaling of the business is going to be based on finding, business partners that are entrepreneurial, that are looking to provide. We like to describe our business model. We are a missionary business model. We are not a mercenary business model, right? We're not just out to just make money. We're providing a mission to our communities by providing a service to help reduce your pain and inflammation, to keep you moving. Again, I say it out loud again, to champion your personal success, which I really love our synergy with your company as to what we're doing with OrthoLaser as well.
Now, is from the standpoint of delivering customers to the business, is it prescribed from a doctor or is it mostly direct marketing to the life to come in, or a combination of both? What's the vision for that?
So it's a great question, and it is a combination of both. We want our physician owners to be able to identify patients that have these, complex issues, and what we can do to provide alternative sources for pain relief. So physician referrals are a mainstay of where we get our treatment programs from, but we're also now talking direct to consumers. And now you can do something called asynchronous medicine, asynchronous telemedicine. So, I always say, think about erectile dysfunction. So for men out there that want to take Viagra, well, you don't want to run around and raise up your hand and say, I need Viagra. So there is our legal asynchronous telemedicine. So literally you can fill out a questionnaire online, and a healthcare professional can review your medical history and then provide you counsel that this is a treatment that's available for you. And then we call that our road to room strategy, where we're getting patients that are hearing about us and then coming in, where you're evaluated by a clinician to make sure that you fit what we're trying to do. And then we can get you referred in. So it's both. It's a direct to consumer model. And then it's also the direct physician referrals, which I think is great, right? Because this is validated by physicians, MDs, DOs that have spent time to understand and learn our technology, and then can make that recommendation as well.
It's interesting as I look at the application of this business. I mean, you could talk about this forever, but like addiction recovery services as well. If somebody is actually coming off of opioids, they still have the pain, and this could help them with that process and even actually speed it up.
Yeah, no, there's no question. I'm going to throw another one of my hats into the ring. I'm on the board of directors for Pain Scripts, which is a company that's using medical technology. There are some new codes, the remote therapeutic monitoring codes, so that our primary care doctors in particular were the doctors that were on the front lines of the opioid epidemic. This is where people come in, they complain of pain, they have issues. And for decades, they were writing prescriptions for opioids for patients that had chronic issues that were opioid naive. And again, I want to be very clear to the opioid zealots that may be listening out there. I am not against opioids in total. For end of life, for cancer patients, for severe trauma, we need, you need pain medication for these patients, and the opioids has its role. The problem is if you have knee arthritis, if you have hip arthritis, and we just carelessly start you on opioids, you're now going to have hip arthritis and you're going to be addicted to opioids. It's just that simple. And so with pain scripts, it's wonderful. It's a way in which these primary care doctors can generate additional revenue through insurance companies, through Medicare in particular, by taking the time and energy to communicate with your patients about the process of either weaning you off of medications, or if you're on Suboxone, or if you're long-term, we can help you to maintain where you are and provide counsel so that our patients are getting better care. And then the doctors are fairly compensated for their time. And overall, it's a win for all of the patients that are involved. So that's a company called Pain Scripts, and we're partnering with primary care doctor and groups across the country at this point as we are trying to get that information out as well.
Seems like this whole space of trying to not avoid opioids, but also just to encourage other forms of pain relief. I remember when I had it's about 6, 7 years ago, I had hernia surgery. And I purposely picked a physician and surgeon who he was an athlete. He was a marathon runner. And so at the time I was a big runner and I just wanted to get back to running. And so we had a connection. He could do that. And then after the surgery, I remember the weird conversation of, listen, I have to offer you these meds for your pain. I'm going to tell you don't need them. You don't have to use it. And you should do this instead. And, he said, take some Tylenol, but he also gave me some things that how to avoid using my muscles to get out of bed and everything else to avoid the major pain spikes, as he called it. And I didn't know what he was doing at the time because I just thought he was being nice to me and everything else, but I didn't take any medicines. I took Tylenol and I had pain, but I used his technique to get out of bed, which I'm sure it worked, but I look back on that relationship with him and I appreciate the fact that he was not trying to give me the simple fix. It was, hey, follow these steps and think about it and you'll do better.
The number one way in which you can help to reduce pain as far as multiple treatment options is communication, which is exactly what this doctor did. There are new modalities, virtual reality, where you can have people wear the virtual reality glasses as they're undergoing surgery. We do spinal fusions now without general anesthetic, and they go on the same day. I mean, it's because of the multiple modalities that we have that are non-addictive. And both, the CDC for the first time in about 5 years put out new guidelines for opioid prescribing, and this was about a year and a half ago now. Previous to that, they basically said, hey, it would be smart if you use less opioids, but they did a deep dive in the literature. And to your point, they looked at all of the various options that were out there, whether it was pharmacologic or non-pharmacologic. And they said, look, for cancer, for end of life, for acute trauma, opioids have their place, but try to use less opioids, especially for opioid naive people, and let's give you some alternatives. And so long-acting anesthetics, non-addictive oral medications, things like that was in the pharma world. And then in the non-pharma world, they took a look at physical therapy, massage therapy, acupuncture, laser therapy, and they gave all of these now recommended options that are available for primary care doctors as well as surgeons and others to have a strategy to try and minimize opioids for your patients, because at the end of the day, you said it out loud. It hurts for about 2 to 3 days, but after about 2 to 3 days, it's just not that bad. So what can we do to get you through the worst of it at that time?
Exactly. Well, Doctor, this has been a fascinating conversation. We went deeper on some subjects that I didn't think we would, but I really enjoyed it and I learned a lot. And by the way, the going down the biology class was great. I appreciate that. And I can't wait to watch your business. Are you going to be, but I'm hoping North Carolina is on the list of approved states.
So we are in Fayetteville, North Carolina, as we speak. We opened up about 6 months ago. We have 2 centers opening up in South Carolina relatively soon as well. So again, we're going to grow slow to really sort of expand. Our program is really over the next 2 years to probably double the number of franchises that we have across the country, get to a point where we've really got it figured out, and then we're going to try and really explode across the country and make this as an option for everyone.
Well, let's make a note to check in maybe next year. And I'd love to know how the business success is going, but I'd love to learn how you're impacting lives in these communities and helping them. I'm fascinated and would love to learn more.
Yeah, no, Joe, I really appreciate the opportunity to be able to share, the things that I'm passionate about. I still am a very busy clinical orthopedic surgeon, but, I do take a lot of time out of my schedule to travel, educate, and do all of these other things to try and affect positively as many patients as I can with all of the things that I've learned.
Well, I would certainly appreciate your time, and I'm really glad that Brooke, our connection, got us together to speak today. So thank you so much, and best of luck with your business, and all the best to your family.
Thanks again for the opportunity. I really appreciate it.
And that wraps up our time with Dr. Scott Sigman on 101 Mobility Conversations. We'll catch you on the next episode. Take care.